Okay, I'm going to give a very quick run through and overview of the Dallas programme, which was a £37 million digital health programme that was funded by Innovate and was spanned Scotland and England. Now, okay, I want to acknowledge our funders and also the Dallas community co-investigators and the advisory board chaired by Professor Anne Rogers, and which Carl May was also on. Okay, we know that digital health has great potential, and policymakers see it as something very important to invest in because of the challenges facing healthcare systems. And those challenges are very well known and very well characterised: the changing population demographics, ageing populations, the growth of chronic illness and multimorbidity on a background of austerity. And digital health is seen by policymakers as having been the answer to many of our problems. But one thing that's been clear is that there's a large translational gap. There are many digital health interventions that have been advocated and many trials that have taken place. But everywhere, the implementation of digital health services has proven problematic and difficult. So one of our tasks in the Dallas evaluation was to learn through this large-scale deployment about what the barriers were and also the facilitators and how you might circumnavigate those. Now, I'm going to tell you some things that seem very straightforward and basically, well, everybody should know this. But I'm not embarrassed about restating some simple truths because, again and again, we see in the media costly implementation failures. We see it in the UK, we see it across Europe and internationally. So it continues to be a major problem. So just to give you a quick overview of the Dallas programme, the vision was to transform digitally supported self-care. There were 4 communities funded. iFocus and Year Zero spanned Scotland and England. Living It Up was the Scottish programme, and My took place in Liverpool. These communities did not have services ready to roll out and deploy when they were initially funded. So this was not like randomised controlled trials at all. The aim was for these communities to engage with service users and co-design and develop services going forward, which they spent much of the first 18 months of their programme doing. And they were deploying a whole range of different types of services, ranging from apps to personal electronic health records, through to telecare services, through to digital portals, and the like. Our aim was to look at the effect on individuals and systems. DataBuild, a private company, was looking at the effects on the economy. And I'm talking today about the evaluation relating to the implementation factors. It's to be clear that we use normalization process theory, and I'm going to talk about that in the next slide, which has 4 constructs as our underpinning theoretical framework. And also that the values underpinning the deployment were, as voiced by the funder, was to the 6 C's, that this programme was supposed to enhance choice, control, community, collaboration, contribution, and connectedness. So what were our methods? This was a 3-year longitudinal study, and we undertook interviews with a range of key stakeholders. It's important to be clear also that each of these communities could be made up of 20, 30, or 40 different organisations and partners. These communities consisted of NHS, social care, third sector, voluntary sector, industry partners. So it covered a broad range, and we were covering that range of stakeholders. We also undertook focus groups with professionals and the public who were using the services. We attended Dallas Leads meetings. We undertook ethnographic fieldwork. We would observe co-design events that might involve hundreds of individuals. And we took a framework approach to our analysis. I've shamelessly stolen this slide from Kate O'Donnell, so if you're interested in looking at it, it's visible on SlideShare. But it's a nice slide that illustrates NPT. And the two constructs of coherence and cognitive participation, which can be thought about as the thinking about doing. Coherence, the sense-making work people have to do when they engage with something. And cognitive participation, the engagement work that people undertake when enacting a new way of working. Whereas the collective action and reflexive monitoring are the doing work. What are the resources that you need, collective action, when you're operationalizing things? What skills and training? How does it affect roles and responsibilities? And reflexive monitoring, how do you appraise or judge those things? So this was our underlying conceptual framework. So what were the lessons learned? Well, basically, we took a whole program approach, and we took a lens which looked at macro, meso, and micro aspects. The policymakers would have you think that the market is ready and willing to jump into digital health. The truth was quite different. The market was not necessarily ready. Companies, for instance, international players who came into the UK looking to implement e-health initiatives talked about the market being difficult to navigate. The NHS may seem like one system, but especially with devolution, it isn't. But also, every organisation in the NHS works differently. And industry talked about the problems of who did they contact, of having to reinvent the wheel when they went from area to area. Thinking at a high level as well, interoperability is a big thing in digital health. We all know that people are in our practices and they move from one practice enough, the difficulty of transmitting information between practices because of interoperability issues. Interoperability sounds like a good idea. Industry said, yes, it is a good idea. But the market said, is that where our priority is? Or are we more interested in increasing market share? So it became apparent iFocus, one of the communities, had interoperability as a main plank of interest for them. And the technical solutions seemed possible. But what was more difficult was getting companies to sit at the table with them. Also in terms of policy, information governance regulations are interpreted differently across the NHS and are not fit for purpose when you're trying to roll out consumer digital health interventions. You may not realise it, but if you've got a personal health record, it is your property. As soon as some health professional, the NHS, writes in it, it becomes NHS property. And there are all sorts of ramifications about data sharing, and those have not been resolved. There's also the wider infrastructure issues, and across the UK, broadband internet is not available as you would want everywhere. At the meso level, organisations like NHS trusts were working on a background of austerity that affected the resources that they had. They also had the issue of about change. In NHS England, there was a complete transformation and reorganisation that affected the implementation greatly. There were also the issues at the local level in health centres and in secondary care of information systems that were not fit for purpose, but also of problems of Wi-Fi. If you're wanting people to use apps and tablets and the like, and health centres don't have Wi-Fi, then it just doesn't happen. Equally, somebody could be trying to use a system in secondary care, but firewalls didn't let them connect with patients' apps or electronic health records. So real issues there. And also at the industry level, the issue of risk. Some of these communities tried to engage with big players like Tesco and get them to put digital health interventions and technologies and equipment on their shelves. There was not great appetite for that. One community had a partner that was a large utility firm, and they planned to roll out a program called Warmer Neighbourhoods, which would provide sensors in people's homes. That partner withdrew during the program, and that meant that whole service did not take place. And that was because of their concerns about risk, about the risks that would happen if something went wrong. And some of these players in industry who are not in the health field just now were not necessarily willing to engage. And then we get to the micro level, the public. We're told that consumers want digital health, and many do, but they need help to do that. And there was the issue about access, both for professionals and for patients. If you have a system that requires people to have iPads and you don't have it, it's a problem, and professionals had that. But also patients. There's issues about health literacy and digital health literacy. And I remember one quote from a patient which said, they said, would I like a tablet? And I was looking for the water because the only tablets I've ever had is the ones they give me with my water. So not everybody's up for it. And also, even if you have the digital skills, we all live busy lives. And we have our own life worlds. And self-management is only a part of that. And that was an issue too. Fitting in digital health into your lifestyle could be difficult. Equally, people lacked skills, and health professionals lacked skills also. And then there was the issue for both professionals and patients about security and safety. So what were the key issues? The key issues really were the infrastructure, both at a national and local level, which was inadequate and not fit for purpose. Policy needs to be updated if we are going to embrace a consumer-driven kind of digital health market. If that's what the government wants, then they need to rethink their policy. Interoperability is a great thing. We keep talking about it. It seems difficult, but I think it's going to need incentivized if we're going to make a difference. Accreditation and quality assurance was a big issue in terms of the concerns people had about safety and security. Patients were happier to engage with digital health if their physicians said they thought it was a good idea, it was safe. Physicians were more likely to engage with it if official bodies had accredited them and also had assured them that these systems were safe. There were market concerns about accountability that need addressed. The market is not necessarily ready to embrace it. and we need to think about how we could change that. Engagement and enablement at a local level will be important. A lot of these in communities invested a great deal in digital champions and digital hubs to try and do upskilling. We'll need to do more of that if digital health is to be rolled out. Readiness issues are ubiquitous, but I don't think they're necessarily insurmountable. These challenges need to be acknowledged and addressed if we're to make deployment at scale realize something that can be realized. Thank you.
So 5 minutes for questions for Frances, please. Can I start then? Can I just ask in relation to, we've an interest here now in summary care records for patients, and you were talking about the micro level. Again, I'm not that well informed about what did and didn't happen in the UK, but what lessons do you think people can take from your work in relation to the usage of a summary care record for people?
Is she talking about a summary care record that the patients can use and see, or one that's just more widely used?
It's probably the former, but of course that's part of the problem because there is a certain amount of misunderstanding about what the purposes would be. But it would be principally about people's, patients, citizens' records.
Yeah. I think patients and the public, there was a great deal of enthusiasm for digital health. So it's not that people were necessarily negative. But if you're wanting to reach the wider population and you're not wanting to widen inequalities, then there's going to be a lot more investment and effort made in trying to enable people to engage with that. And also to realize that people have more important things to do, in their view, often than manage their chronic illnesses. That's not necessarily their top priority. It will be for some people, but not for all. And we have to think about tailoring these services and making them more fit for purpose. A one-size-fits-all will not work.
Hi, I was interested in your comments about information governance, and I've come across some interoperability and information governance interpretations and people disagreeing about what they mean. What do you think the answer is? Because obviously a lot of this stuff is kind of enshrined in law and policy, so how do we kind of get around something that's more common sense?
I think that's a big issue because everybody, I think, recognizes a problem, but it's not being solved. But it actually is a huge barrier because if you have to negotiate information governance at every trust level across the UK, that can act as an insurmountable barrier. And I think as researchers, we can relate to that in terms of research governance as issues. And that variability, I think, at a really high level in Scotland, England, Wales, Northern Ireland, has to be addressed in legislation. There needs to be a much more straightforward rules about it, and also about interpretation. And there needs to be almost an appeals body when things are being interpreted very differently in one organisation compared to another.
Okay, I think, thank you very much for that, Frances. Thank you.